Yeah.
Good morning, everybody. Welcome to our IASNM webinar. We have a very accomplished speaker with us today, Dr. Akshay Sood, and it is my great pleasure to welcome him to this program. About Dr. Sood, he did his medical school training at AIIMS in New Delhi, and following completion of med school, he did his postdoctoral bench-side research for 2 years in uropathology at Johns Hopkins. And he did his residency training in general surgery and urology at Henry Ford, Detroit, with Dr. Menon. Currently, he's a fellow of the Society of Urologic Oncology at the University of Texas, MD Anderson Cancer Center. He has published 175 plus white papers, and he is interested in pelvic urologic cancers. Personally, he loves to hike with his dog. He mentions in his bio. I would love to know at the end of the talk what kind of dog does he have, and he also loves to paint, read, and swim. So welcome, Dr. Sood. We are really happy that you're here with us today.
Good morning, everyone. Thank you, Dr. Sethi, for that kind introduction. I have a German Shepherd dog. He's right now away because he won't let me present. But anyway, thank you, everyone. Thank you, especially Dr. Takakar and Dr. Rao for this wonderful opportunity. And I'm really glad to meet you all virtually. So over the next 45 minutes or so, I'll try to discuss with you all from a urologist, from a urologic perspective, the role of molecular imaging and how we utilize it for diagnosing, risk stratifying, and surgical and post-surgical management of these patients with prostate cancer. I don't have any disclosures except that I'm a surgeon talking to imaging experts. So just take that with a grain of salt, whatever I discussed today. But yeah, I've divided the talk into 3 different sections. First, I'll discuss the utility of molecular imaging in the preoperative setting, and we will talk about both how and if the molecular imaging plays any role in diagnosing prostate cancer, meaning the primary diagnosis of prostate cancer, then what are the implications for focal therapy. And I will discuss with you a little bit of an experimental approach that we have been practicing over the last 5 years. So I'll show some results from that. I will also discuss how molecular imaging helps us in risk stratifying patients, localized versus non-localized disease. Then I will discuss some of the upcoming things in the role of PSMA scans or PSMA technology in guiding surgical therapy intraoperatively, and then ultimately we'll discuss the role of molecular imaging in the post-operative setting. And I know the last lecture that was given by, I want to say by Dr. Savir, she discussed a few things of this nature. So I try to keep that in mind and focus my talk more on a surgical perspective. So because I know she talked the utility of molecular imaging in both kind of risk stratifying and post-operative management or patients with BCF. So we'll start with the preoperative setting. So we know that prostate cancer is a common cancer. It's the most common cancer in men in United States. And it's the second most common cancer worldwide, just behind lung cancer. Approximately 1.4 million cases of prostate cancer are diagnosed globally every year, and approximately 250,000 cases are diagnosed every year in the United States. So obviously a very a problem of great magnitude. So before the multiparametric MRI era kind of emerged, maybe 10 or 15 years ago, urologists used to diagnose prostate cancer by using PSA, digital rectal exam, and a transrectal ultrasound guided biopsy. And that led to several problems. It led to problem of underdiagnosing patients because we were not hitting the right targets, or it led to overdiagnosis of indolent cancer like Gleason 6, which we probably should not have been diagnosing. So there was a lot of overtreatment as well as undertreatment in patients who were low risk and high risk respectively. So as you guys have been at the forefront of leading the imaging kind of revolution in prostate cancer management, multiparametric MRI has really changed how we diagnose and manage prostate cancer now. And these are kind of the 3, in my mind, landmark papers that have come out in the last decade that have really changed how we manage prostate cancer. We know the paper by Ahmed et al., that the PROMISE trial, which showed that, and I will discuss those results in the next slide. So basically, the PROMISE trial essentially showed that when you compare multiparametric MRI to simply systematic transrectal ultrasound guided biopsy, the sensitivity of multiparametric MRI in diagnosing clinically significant cancer, which we commonly, the definition we use is 3+4 or greater, not the 4+3, which they used as the primary definition. But regardless, if you use the 3+4 definition, you can see that the multiparametric MRI has a far greater sensitivity of 87 compared to just 60 of a transrectal ultrasound guided biopsy. So clearly significant improvement in detecting clinically significant cancer with the MRI use. But with that said, if you still the sensitivity is only 87%, it's very good compared to what we had before, but still there is a chance that we miss significant cancers. And we know from other papers, which I will not discuss today, that there is a chance approximately 15 to 20% that we can miss clinically significant prostate cancer, Gleason 3+4 or above, especially when they are less than 3 or 4 millimeters in size. So that brings us to the question, if we utilize molecular imaging in this space, can we improve the initial diagnosis of prostate cancer further, building upon the MRI results that we already have? Again, over the last 10 years or so, there have been multiple investigations kind of combining the use of MRI, PET-CT, and different radioligands to see if adopting molecular imaging in this space helps improve the initial detection. So these are two kind of studies. The Eber et al. Study is very well known, and what they did, I forget the exact number, but I think they looked at approximately 50 patients, and these patients underwent both multiparametric MRI and a gallium PSMA scan. And what they found, the AU area under the curve improved significantly, I think around 85% with the combination imaging compared to about 65% with MRI alone. So this paper gave us a kind of a signal that maybe there is some role for incorporating PSMA upfront, even when we are not really considering high-risk disease for staging. This is just for diagnosis of primary prostate cancer. And similar findings were noted by Chen et al. Sorry about that. But both of those studies were retrospective in nature, and we know there are obvious drawbacks with those studies. So over the years, there was this trial designed by Dr. Jeremy Clay, and this was recently published, I want to say just a few months ago, in the Journal of Nuclear Medicine. So they did a head-to-head prospective comparison, answering the same question, essentially, whether adding a PSMA PET scan to multiparametric MRI, does it increase one, local staging, meaning T3A, T3B disease diagnosis, and also does it help in diagnosing intraprostatic lesion, meaning can we better localize lesions within the prostate as well? And the answer to both is no, or to all three is no. Actually, multiparametric MRI is superior in anatomic delineation, which is not a surprise because it's an anatomical scan, whereas PSMA is a molecular scan. So PSMA would not really help in T staging as such. So multiparametric MRI did outperform PSMA in detecting both EPE and essentially extraprostatic extension and seminal vesicle invasion. So clearly a multiparametric MRI is superior in that regards. But with regards to intraprostatic lesional detection, also what you can see here is essentially PSMA, PET-CT, multiparametric MRI combination. They essentially all have equivalent sensitivities, all in kind of mid-80s. So again, combination versus either of the imaging alone doesn't really provide you any benefit. So it seems based on this imaging study that multiparametric MRI is sufficient enough for initial diagnosis of prostate cancer, as it gives us both T staging accurately, as well as it gives us the intraprostatic lesional kind of geography of that. So where do we stand? Actually, we are right now just submitted this invited review article to European Urology Oncology, kind of discussing these situations. So here are kind of just a summary points. We know that choline PET and examine PET, they don't really help us in intraprostatic delineation because they both get uptaken by, not in a non-specific pattern in the prostate, they get uptaken by BPH nodules as well as prostate cancer foci. So there's a lot of false positive. So these imaging modalities don't really help us in intraprostatic delineation. PSMA does help a little bit, but like I showed you, the head-to-head trial, that the added benefit over MRI is not really substantial. So it may, and I will come to that point in a second, that there may still be some role for adding PSMA imaging in the initial primary diagnosis of prostate cancer. With regards to T-staging, none of the PSMA scans have any value in T-staging, and multiparametric MRI and digital rectal exam should be standard of care for T-staging in prostate cancer patients. So like I said, with all that said, does PSMA scan still has any value in the setting of when we are trying to look at intraprostatic lesion? So what the Soni et al. Paper, which I discussed previously, what they did see is that although it did not increase the detection rates as such, it does improve the definition of the lesion extent, meaning how big of a lesion it is, and is it crossing the midline of the prostate, and is it crossing into different segments? And as you know, different segments, apex, base, mid, and anterior, posterior. So we always divide the prostate like that. So it does improve that, and that can have, as the imaging has kind of evolved over the last decade, so have the treatments that we provide for prostate cancer patients. 10 years ago or 20 years ago, the only real treatment options we had were radical surgery, radical radiotherapy, and active surveillance, which was still upcoming at that time. But now, obviously, active surveillance is a very well-established modality of treatment, but focal therapy has also come as a significant modality which can be offered to the patient, especially patients in which we don't think they have extraprostatic disease. So with that said, I do think PSMA scans may have role in patients where we are considering focal therapy. So just a little bit of a primer on focal therapy, because I know I'm talking mainly to the imaging folks here. So Dr. Ahmed, whose paper was the PROMISE trial we just discussed, he has done a lot of work from the UK about the focal therapy. So this is, again, briefly, I will discuss the index lesion hypothesis. So what the index lesion hypothesis is based on is this classic paper by Liu et al. And subsequently, there have been multiple papers in high-ranking journals, where what these papers have shown is when you do a kind of a molecular phylogeny of prostate cancer lesion evolution, once it comes out of the prostate, usually it's a clonal lesion that comes out of the prostate. So as they show here, that prostate cancer as such is a multifocal disease. Approximately 60 to 70% will have multifocal lesions in the prostate. But the lesion that gets out and leads to metastasis is usually from a single lesion, and the other lesions get suppressed. So that's the index lesion hypothesis, that within every prostate cancer, even though it's multifocal, there is a single lesion that's aggressive, that gets out into the lymph nodes, and then the subsequent metastasis actually happen from the lymph nodes. And there are good papers that show that. So the rationale for focal therapy then lies on the fact that if we can identify this index lesion and treat it, then we don't really need to treat the whole gland and just treat this lesion focally, and maybe we can have equivalent oncological efficacy as radical treatments, but by not doing whole gland treatment, we can save the functional functionality for the patient in terms of urinary continence as well as sexual dysfunction, because radical therapies are associated with high rates of sexual dysfunction, close to 70%, and urinary continence maybe about 5%. So on the left side is, again, one of the classic papers by Dr. Ahmed et al. Published in Lancet Oncology in, I think, 2012, where what they did was, based on this index lesion hypothesis, they performed focal HIFU in 41 patients. And what you can see here is on these curves are basically functional curves, erectile functional recovery and urinary continence recovery. So within 12 months, almost all patients were continent of urine. So 95% patients were continent of urine, and 84% patients had erections sufficient enough for intercourse, which is a substantial difference from radical therapy. At 1 year mark, most radical therapies only report a 30 to 40% rate of erectile function recovery. So huge benefit of focal therapy here. What they also say here is that about 8% of the patients had cancer recurrence and clinically significant cancer recurrence. So 8% was their rate of clinically significant cancer recurrence within 12 months. But one caveat with this paper is that after treating the prostate cancer, they were only biopsying the lesion that they had ablated with focal HIFU. They were not performing systematic prostate cancer biopsies. And I believe that's why the rate of clinically significant cancer recurrence was noted to be so low in this study. And on this side, we did a systematic or a semi-systematic review of the literature of the key studies that were published in the last decade on focal HIFU. And what you can see is the more recent studies that have been published in the last 5 years or so, all these studies were performing protocol template biopsies of the prostate, not just of the treated lesion, but of the whole gland. So their biopsy template was whole gland. And you can see when they perform whole gland biopsies, clinically significant prostate cancer residual rate is close to 30 to 40%, so much higher than the original study. And it makes sense, as I will show you in a second here. So we performed these preclinical studies. As you know, the gold standard for any kind of prostate pathology is to go back to pathology, histopathology, and do whole mount sectioning. So in our center, we performed a whole mount analysis of 100 radical prostatectomy specimens, patients who had already undergone radical prostatectomy, but they would fit the criteria for focal HIFU per Ahmed et al.'s paper if we had offered them that option. And then we performed histopathologic analysis of where these prostate cancer lesions were, and we simulated focal HIFU for these patients. So just based on the prostate gland size, out of these 100 patients, 75 would not actually meet the focal HIFU criteria, just based on the prostate gland size. But 25 patients who did meet the HIFU criteria based on the prostate gland size, if we were to perform focal HIFU near the dominant prostate cancer lesion site, as Ahmed et al. Had done, with a 5 millimeter margin away from the peripheral zone so as to not damage the nerves, you can see almost 60% of those patients would be left behind with clinically significant prostate cancer. And this is, again, not far off from what we are seeing with these newer studies that are performing whole gland biopsy, that the rate of failure is 40%. So there is that difference. And here we simulated a new procedure hypothetically at that time. And this was based on some of the data review that we had performed. And I will not go into the detail, but we know from other surgical procedures that are performed on the prostate that you don't really need to save the majority of the gland to provide functional benefit. You can just save a small sliver of the gland and you can preserve the functional quality of life for the patient, because if you save one-sided nerves and a capsule around it, you should be able to get good results with that as well. So we simulated that and we termed it precision prostatectomy. And what we saw here in our simulation is that if we were to perform this procedure, approximately only 15% of the 100 patients would have clinically significant cancer left behind. And based on these results, we proceeded to perform a phase 2 clinical study of precision prostatectomy. And here what we see, we enrolled 88 patients overall, and most of these patients, as you can see, were either favorable or unfavorable intermediate risk prostate cancer patients. And they underwent this surgery called the precision prostatectomy, where on the side of the dominant nodule, we perform a standard radical prostatectomy, whereas on the side of the non-dominant cancer nodule, we spare a part of the capsule of the prostate. Usually you would go outside and just try to preserve the nerves, meaning here. But in this case, we were trying to go somewhere here. Obviously, you cannot be so accurate that you can travel between this plane surgically. So we were traveling maybe somewhere here or somewhere here. So we were leaving part of the capsule as well as peripheral zone behind. And I will share with you a quick video since I think we are on time.
In this video, we describe the novel technique of precision prostatectomy, a form of surgical therapy for patients with localized prostate cancer. The video has two parts. In the first part, we describe the approach and rationale for performing the Koalis 3D ultrasound-guided transperineal biopsy of the prostate in preparation for the precision prostatectomy procedure. And in the next part, we provide details on the procedure itself. All patients that meet the initial study entry criteria undergo a Koalis 3D ultrasound-guided transperineal mapping or capsular prostate biopsy for evaluation of cancer burden and accurate localization of cancer foci. The patient is placed in the dorsal orthotomy position as depicted and prepped in the usual sterile fashion. The Koalis Trinity platform is used to create a three-dimensional rendering of the prostate using transrectal ultrasound. Here is an example of a candidate for focal therapy. The patient harbors a large dominant prostate cancer lesion on one side and has additional sizable cancer lesions on the contralateral side, which harbor clinically significant prostate cancer as well. Biopsy-naive patients undergo a saturation template biopsy, sampling the entirety of the prostate, as well as targeting the lateralmost peripheral zone, the capsule of the prostate, while patients with a prior recent biopsy undergo capsular biopsy only. Cores are taken at 5mm intervals. With these templates, we are able to maximize our efforts to diagnose any significant cancer in the prostate capsule that is planned to be left behind in situ, on the side of the precision prostatectomy. The video animation shows the zonal anatomy of the prostate in its 4 basic anatomic regions, as described by McNeil. The view is from the abdominal cavity looking down into the pelvis, as during a robotic prostatectomy. It again demonstrates a large dominant prostate cancer lesion on the right side and additional sizable cancer lesions on the left side. The video clip demonstrates the pelvic fascias, the capsule of the prostate, and the veil of the nerves around the prostate forming a hammock. A significant proportion of nerves are invested close to the prostatic capsule and the denomviase fascia, and are thus damaged during a radical prostatectomy. It is important to differentiate between the surgical planes for radical, simple, and precision prostatectomies. A radical approach removes the prostate with its capsule and periprostatic tissue to the level of the lateral prostatic fascia. The goal of a simple prostatectomy is to remove the adenoma that is mostly confined to the transitional zone, while the peripheral zone is mostly left intact and thus protecting erectogenic nerves on both sides. Whereas the plane for a precision prostatectomy cuts into the peripheral zone and deliberately leaves behind a 5 to 10mm rim of prostatic tissue that maximizes removal of cancer foci while protecting erectogenic nerves embedded within the prostatic capsule. Here, we see a radical prostatectomy plane with conventional nerve sparing on the right side, the side of the dominant cancer lesion. On the contralateral side, the precision side, the dissection is started anterior to the vas deferens and seminal vesicle complex, while preserving all layers of denomviase fascia with the included erectogenic nerves. The dissection is then continued 5 to 10mm into the prostatic capsule, deliberately attempting to leave behind a thin rim of prostatic tissue along with the seminal vesicle and ejaculatory duct complex. Here is a demonstration of the removed prostate specimen with its unilateral seminal vesicle and contained cancer foci. The prostate remnant is measured with the aid of a drop-in ultrasound probe. Systematic needle biopsies, via a suprapubic or transperineal approach, may be taken from the remnant prostatic tissue and sent for frozen section analysis. Completion prostatectomy is performed if the frozen biopsies show residual cancer. Patient positioning, port placement, development of the space of Retzius, bladder neck incision.
Okay, I'll stop here. In the next part, we show the actual surgical footage, but I'm not sure if people will be interested here. I'll be happy to share it later if people do want to see that. But yeah, based on kind of this approach that where we spare only about 10% of prostate, we saw really good outcomes with regards to functional recovery. As you can see, they match pretty much the curves that I showed you initially with regards to the focal HIFU therapy. By 12 to 24 months, you can see almost 90%, 95% of patients were continent with 0 pads, and everybody was continent if we counted the social continence as 0 to 1 pad. With regards to sexual function recovery, again, you can see patients who came in preoperatively who were potent. By 12 months, almost 90% of those patients became potent again. And when we look at all comers, about 85% of those patients became potent. So again, much in line with the focal therapy results that we saw from Ahmed's study. So again, kind of proves the principle that you don't really need to save the whole gland. Even a part of the gland that's left behind will be enough to provide you with the functional benefit. And with regards to the oncological outcomes, we did see much improved outcomes, although of course our follow-up is short, but again, our follow-up is still longer than most of the HIFU studies at a median follow-up of, I want to say our median follow-up was about 24 months. So we reported 36 month outcomes here. So as you can see, at 36 months, 90% of patients had remained free from needing any kind of secondary treatment, and approximately 94% of patients had remained free of clinically significant cancer at 3 years. While if you look at the other studies that I showed in the table, somewhere between 30 to 40% of patients had clinically significant prostate cancer diagnosed within 6 to 12 months. So we believe there is definitely some role for precision prostatectomy in the setting of patients who want to preserve their functional outcomes in localized prostate cancer. So again, kind of going back to the PSMA study, all this work was done just with help of transperineal saturation biopsy with or without multiparametric MRI. Even multiparametric MRI was not routinely used because this study was done between 2016 and 20. So MRI was not that easily available to us. And none of these patients had PSMA done prior to surgery. So we are writing up a trial, and we hope that we can incorporate the multiparametric MRI and PSMA results and guide the precision prostatectomy even better for the patients, how we plan our surgical incisions and improve their outcomes. Now kind of moving on to the second part of the first section, how PSMA helps us risk stratify patients with prostate cancer. And like I said, Dr. Sabir, I think she did cover part of it last time, but I'll just focus on some of the surgical aspect of it. So we know this study by Hoffman et al. Published in Lancet, which showed that PSMA has much higher sensitivity in diagnosing nodal disease when it comes to, as compared to conventional imaging. I think conventional imaging had a sensitivity of about 23%, and PSMA had a sensitivity of approximately 85%. So huge benefit for PSMA. But as you all also know, that pro-PSMA study did not perform histopathologic confirmation of nodal disease. And then since then, 2 subsequent studies have come out, one from the UCLA UCSF group and the other from the Hopkins group, which both have performed the histopathologic confirmation, meaning that when they were comparing the sensitivity of PSMA in detecting nodal disease, all these patients did subsequently undergo surgery. And as you can see, the sensitivity is not really that high. It's not 80%, it's approximately 40%. And these results were very consistent across both studies. So again, PSMA does improve nodal staging a little bit, but the benefit is not as high as we had at least hoped initially. So unfortunately, we still cannot completely rely on PSMA to tell us which patient should undergo lymphadenectomy or not. So kind of just a summary statement here that looking at all the available data at this point, the PET imaging is associated with incremental improvement in nodal disease detection rates. But for now, it should not be used to, a negative PET should not be used to forego pelvic lymphadenectomy in a prostate cancer patient. But we do use PSMA PET very frequently in high risk or unfavorable intermediate risk prostate cancer patients in our clinic, because although it may not be very accurate for nodal disease staging, it is very accurate for other systemic staging, and it clearly it performs superior to bone scan as well as CT scan. So that's kind of become the model here, at least at MD Anderson, that we are using more and more PSMA because it's just a one test and gives us all the information that we need. And on the flip side, we know that the PSMA PET scan does have very high specificity in detecting nodal disease, close to 98%. So if the PSMA PET does show that a patient has nodal disease, then it can facilitate discussion regarding whether they would benefit from local therapy, whether they should just have systemic therapy. Again, this is a field that's very rapidly evolving. We don't really know what's the ideal treatment for node positive disease patients is, even with conventional imaging, and we don't know at all what is the ideal treatment for patients is who have nodal imaging positive only on PET scan. There are two papers that I'm sure you guys are aware of. One is a paper by James et al. From the Stampede trial. And this is all based on conventional imaging, which essentially suggested that if you have node positive disease on conventional imaging versus not, and you receive, and both arms receive systemic treatment, but one arm received local radiotherapy versus not, you can clearly see that the patients who received local therapy did much better compared to patients who did not. So clearly there is a role for radiotherapy, but again, this is for conventional imaging. Similarly, we performed a NCDB-based analysis where we looked at any local therapy, it could be surgery or radiation, and we also saw similar results that there was a benefit for performing local therapy in patients who have clinically node positive disease. And surprisingly, for both these studies, actually, the hazard ratio was pretty similar. For James et al. Study, they noted almost a reduction by 50%, so a hazard ratio of 0.5. Our study also noted a hazard reduction by 60%, so a hazard ratio of 0.4. So again, this is very kind of evolving field, so we don't really know, but the PSMA, again, will be helpful in this setting and guiding better treatment for the patients. Now, kind of moving on to the second section of the talk, that can utilizing PSMA probes intraoperatively help us guide our extended pelvic lymph node dissection. And I'll go into why this may be a good question to ask. And most of the data for this comes from the Italian group at San Rafael. So we know that there's no doubt that pelvic lymph node dissection is an excellent staging procedure. It is the best staging procedure that we have for lymph node status, but it does come with significant comorbidities. This is a systematic review that was published in 2017 in European Urology, and what they found after extensive literature search was that none of the studies have consistently and substantially shown that there is an oncological benefit for doing extended pelvic lymph node dissection in patients with prostate cancer. But what they did find is that in performing an extended lymph node dissection is associated with more complications. Patients tend to have longer length of stay. They tend to have more higher blood loss. They tend to have higher operative times. And more significantly, they tend to have higher rates of symptomatic lymphocytes, approximately double. So these are considerations when we think about performing extended lymph node dissection in patients versus not. And then on top of it, this was a randomized trial that was recently conducted at MSKCC, trying to answer this question: should we be performing extended lymph node dissection in patients with intermediate or high-risk prostate cancer, or versus just performing limited pelvic lymph node dissection? As you can see, their endpoint was biochemical failure-free survival, and they see absolutely no benefit. But they were looking at intermediate and high-risk patients. And another kind of limitation or criticism of the study that had come up when the study came out was that if you look at the two groups that were part of this trial, the limited and the extended, they actually both had similar lymph node yields. I think the median for both was like 13 and 14 or something like that. So clearly, either the surgeons in the limited lymph node dissection were doing more aggressive lymph node dissection, and or maybe in the extended, they were doing less aggressive. So clearly, and surgery is a very operator dependent procedure. So again, that was the drawback of this trial, that given that both procedures had similar lymph node yields, are they just comparing same thing? So of course, we're not going to see a benefit there. We looked at, again, using retrospective NCT data. So obviously this is level 3 evidence. But what we saw is we performed sort of a risk-adjusted analysis to see, is there a cutoff? And you all are aware of different nomograms that exist, such as the Godoy nomogram from MSK and the Briganti nomogram, which give us a preoperative risk for lymph node invasion at the time of surgery. So we thought that maybe the benefit of extended lymph node dissection does not exist for low risk, intermediate, and maybe unfavorable intermediate risk patients. It only exists for patients who are high risk because they have a higher chance of disease being in the lymph nodes. And the more extensive dissection you do, the more chance you give them of cleaning them out and reducing, if not all the disease, at least reducing the overall burden of the disease in the patient. So we performed an analysis, and as you can see, based on the Godoy nomogram, as the predicted lymph node invasion risk went up, if you underwent extended lymph node dissection versus limited lymph node dissection or no lymph node dissection, once you hit this 20% mark here, you start to see a divergence in the curves, meaning that yes, patients who are at higher risk who are at predicted higher risk for lymph node invasion, they may benefit from extended lymph node dissection. So again, we have to keep in mind the benefit, oncological benefit versus the side effects when we discuss extended lymph node dissection with these patients. And to this end, Gandaglia et al. Recently published a paper in European Urology where they thought that, of course, nomograms are helpful in guiding treatment and having discussion with the patient. But what about using PSMA, PSMA guided lymph node dissection real time during surgery? And can that improve outcomes? So I'll share a video that Giorgio shared with me very kindly.
PSMA radioguided surgery to detect nodal metastases in prostate cancer patients undergoing robot-assisted radical prostatectomy and extended pelvic lymph node dissection. An extended pelvic lymph node dissection is still the gold standard for nodal staging in newly diagnosed prostate cancer. Although PSMA PET-CT has superior accuracy compared to conventional imaging, its sensitivity for micrometastatic nodal metastases is suboptimal. We hypothesized that radioguided surgery with 99M technetium PSMA might identify lymph node invasion in patients undergoing an extended pelvic lymph node dissection at the time of robotic-assisted radical prostatectomy. The objectives were to optimize the synthesis of 99M technetium PSMA imaging and surgery, to assess the safety and tolerability of the administration of 99M technetium PSMA imaging and surgery, and to describe the use of 99M technetium PSMA radioguided surgery in nodal staging. The second objective was to report the pre-planned interim analysis of a phase 2 study aimed at assessing the safety and accuracy of 99M technetium PSMA radioguided surgery in the identification of lymph node invasion. This was a phase 2 prospective single institution, non-comparative, non-randomized study. A total of 100 prostate cancer patients with CN0, CM0 undergoing robotic-assisted radical prostatectomy with an extended pelvic lymph node dissection with a calculated risk of lymph node invasion superior to 5% will be enrolled. Overall, 16 patients were enrolled between June 2021 and March 2022. Among those, 12 patients underwent PSMA radioguided surgery and represented the study cohort. After signing the informed consent, all patients received 68 gallium PSMA PET MRI. 99M technetium PSMA imaging and surgery was synthesized and administered intravenously the day before surgery. A SPECT CT was also performed to document tracer uptake. Study procedures. A dropping gamma probe was used for in vivo intraoperative measurements to identify metastatic lesions at the level of the internal iliac, external iliac, obturatory, and common iliac stations. A positive finding was defined as the count of at least twice compared to the background noise. All positive lesions were excised. Ex vivo gamma measurements have been performed to confirm the removal of radioactive lesion. An anatomically defined extended pelvic lymph node dissection was then performed. Radioactive tissue was excised and compared with the findings of post-operative histopathological analysis. The first patient was enrolled in May 2021. 16 patients were enrolled. Of these, 12 patients underwent 99M technetium PSMA radioguided surgery. All patients had pathologic data available. The average dose of 68 gallium PSMA administered was of 149 megabecquerels. The average dose of 99M technetium PSMA administered was 735 megabecquerels. There were no adverse events to administration of either tracer. All procedures were performed through a transperitoneal approach using the Da Vinci Xi robotic surgical system. After incision of the peritoneum, release of the bladder laterally to the endopelvic fascia, the pelvic lymph node stations were exposed. A dropping gamma probe was used for in vivo intraoperative measurements to identify metastatic lesions at the level of the internal iliac, external iliac, obturatory, and common iliac stations.
che dovrebbe essere negativo è tra 5 e 10. Qui è tra i 10 e i 20.
Positive finding at PSMA radioguided surgery was defined as the presence of a count rate of at least twice as compared to the background reference noise. All positive lesions were excised. Fibrofatty tissue along the external iliac vein were dissected, the lateral limit being the genitofemoral nerve and the distal limit being the deep circumflex vein. Proximally, the extended pelvic lymph node dissection was performed up to the crossing between the ureter and the common iliac vessels. All fibrofatty tissue within the obturator fossa was removed. The dissection was performed from lateral to medial, up to the umbilical artery and the bladder wall. That will represent the medial limit. Lymph nodes along, as well as medially and laterally to the internal iliac veins, were removed. Ex vivo gamma measurements was performed to immediately confirm the removal of the radioactive lesion or to prompt further search in case of a missing signal. All the removed tissue was collected separately according to the site of resection. An anatomically defined extended pelvic lymph node dissection was then performed. Intraoperative measurements with the drop-in gamma probe were performed at the level of the common iliac and presacral stations. The robotic-assisted radical prostatectomy was then completed. After removal of the prostate, the gamma probe was used to assess the presence of 99M technetium PSMA imaging and surgery uptake at the level of the prostatic fossa after removal of the primary tumor. In the patients who underwent surgery, average OR time was 230 minutes, estimated blood loss were 100 ml, length of stay was an average of 5 days. There were no intraoperative complications. There was one post-operative complication linked to a respiratory complication. On a per region analysis, sensitivity was 63%.
Yeah, I'll discuss those results here. The key results from this paper. So the hope was that we know that PSMA helps obviously in the metastatic disease staging, maybe so a little bit in the nodal staging, but maybe if we use the probe directly during surgery, it may improve the nodal staging. But unfortunately, what they saw here in the 16 patients that they did, and they had a total of 96 anatomical lymph node regions, the sensitivity for PSMA still remained fairly low. It was improved compared to what we saw with the Thomas Hope and the Ken-Pienta study that in the pre-op setting and kind of like extracorporeal PSMA use, the sensitivity is about 40%. When you perform intracorporeal PSMA studies, the sensitivity is 50%. But again, it's not a huge increase in diagnosing lymph node disease with PSMA. So there was a lot, like 50% of the lymph nodes were still missed by performing intracorporeal PSMA. So at this time, again, we're not really sure if PSMA with regards to nodal staging is a good enough study at this point. So just a summary statement, similar to preoperative PSMA staging, intraoperative PSMA use at this time is not sensitive enough to guide EPLND. So for lymph node dissection, I think we just go by our anatomic boundaries for now until we have something new from you guys. So that's kind of summarizes both the pre-op and intraoperative setting. And now the post-op setting, I won't take too long here because I know Dr. Savir touched on this last time, but I do want to mention two of the key studies. And one study has come from Dr. Takulkar's institute from Emory itself. So this is the Empire 1 study, which was started back in 2012 with exomin PET scan. And what the purpose of this study was, we all know that the PET scan is really sensitive in improving the staging of the patient. But the question everybody asks is, when you do perform PET scan, the PSMA or any kind of other radioligand associated PET scan, and you may or may not change your treatment based on that, do the patients ultimately benefit in terms of survival outcomes? And this is what the study sought to answer. So this was a randomized phase 3 trial. It enrolled about 160 patients in 80 patients in each arm, basically one just undergoing conventional imaging and the other going the flucyclovine. And then what they did was the patients that were in the experimental arm who underwent the exomin study, this is just kind of example of two different patients. What the exomin led to is the change in the radiotherapy field. So you can see here, initially before the the exomin scan was done, this was kind of the radiotherapy field that the radiation oncologist had marked out in a patient with biochemical failure after prostatectomy. But once they had the results of the exomin scan, they changed their radiotherapy area to incorporate this positive lesion. And similarly, in the lymph nodal setting, initially their area would have just gone through straight, but when they saw metastasis, they changed the boundary of their simulation to incorporate that lymph node metastasis. And what they see here is the difference, the event-free survival Kaplan-Meier curve here, and what they find is that at 4 years there was approximately 25% difference between the experimental and the control arm, with the experimental arm doing significantly better in terms of control of disease. And again, this is from the supplement part of the paper, and here you can see that not all patients just get treated more aggressively. Actually, some people get treated more aggressively and some get treated less aggressively, but the overall outcome in the group is better. So it leads to both escalation and de-escalation of care for patients. So it's really an important study. And we obviously are not part of it, but it's important for us to know the results of this study as urologists, so we can have a informed discussion with the patient and refer them to our colleagues in medical and radiation oncology. So what you can see here is that approximately 31% of the patients were treated more aggressively based on the results of the exomin PET scan, and approximately 40% of the patients were treated less aggressively because of the results of the exomin PET scan. And lastly, I'll discuss the Oriole study, which also I'm sure most of you are familiar with. So this was a phase 2 randomized trial that had 54 patients in the study, and they randomized patients in a 2:1 ratio, with 36 patients undergoing stereotactic radiotherapy versus 18 undergoing observation. And this was patients with recurrent hormone-sensitive prostate cancer with low volume disease based on the charted criteria. And the key finding is essentially, if you perform radiation therapy to the lesions, you had better outcomes compared to patients who were just treated with standard of care. The reason I included this study is not because of this result, but the result they noted here. Here, what they did, actually, it's an interesting design. So this was, as I said, this was a randomized trial, phase 2 trial. So they randomized patients on the results of the conventional imaging, but all these patients also underwent a PSMA PET scan, but they did not incorporate that knowledge into randomizing patients or even actually making any kind of treatment decision. So it's very different from the Empire 1 study we discussed. They just had a baseline PSMA PET scan for these patients. But what they did was a post-hoc analysis. And in that post-hoc analysis, they separated patients based on the PSMA results. So here are the two groups. And these two groups are basically patients who had PSMA positive lesions. And just by a CT scan, although they were treated based on the CT scans, but if all their lesions that were whether seen on CT scan or on PSMA scan, if they were all treated in the radiotherapy field versus patients who had any untreated lesions based on the PSMA, you can see that any untreated lesion group patients did poorly compared to patients who had a complete consolidation of PSMA positive lesions Again, this is shown in the distant metastasis-free survival here as well. So again, it shows that if you have the knowledge of this molecular imaging, like the Empire one, and you change your therapy fields according to get all the fields treated, you will have a better outcome, or the patients will have a better outcome. So essentially in patients with biochemical failure, molecular imaging not only improves staging, but also improves survival by guiding more appropriate treatment for these patients. So I want to thank again, Dr. Thakulkar, Dr. Rao, and Dr. Sethi for this opportunity. Thank you very much.
That was a great talk. Thank you, Dr. Sood. And rolling over to our Q&A from our audience, if anyone has a question, please feel free to unmute and talk to us.
Hi, this is Dr. Vani from University of Mississippi Medical Center.
Hi, nice to meet you.
Excellent. That was an excellent presentation, and we are really happy to hear from urologist perspective of our imaging. So I was a little bit disappointed some of the results of the PSMA in the node, but we'll work on that, and so hopefully we'll be able to help you more. And so thank you again, that excellent talk.
Yeah, we appreciate your help. Thank you very much.
Great. Any other questions?
Actually, great talk. Does MD Anderson have a PET MR?
I haven't seen much, Dr. Thakulkar. I'm not sure. I can ask. I know I've never seen a patient who has undergone PET MR so far. So I don't think they have, because most of the patients I see, they undergo multiparametric MRI separately, and then they will have a PET CT.
So at Emory, we do have a PET MR, and we've done a few PSMA PET MR scans, and they are, just awesome. We picked up disease that even the MR calls normal.
Right.
2 millimeter nodes and all that. And the reason for that is we have a protocol where we do a dedicated MR sequence of the pelvis for the prostate, and then a whole body PET MR. And the dedicated sequences take about 25 minutes or so. And unlike PET CT, PET MR is obtained, simultaneously. PET CT is, although the name implies it's simultaneous, it's actually sequential. So you get a rapid CT, and the PET is acquired for about 1.5 to 3 or 5 minutes, depending on the quality of your scanner. In the past, it was 5 minutes. Most places now have time of flight scanners for the scan for 2.5 minutes per bed position. The newer digital PET, it's even smaller. But the PET MR, since it's acquired simultaneously, and you're acquiring the patient is on the scanner getting a 25 minute of dedicated pelvis, we keep on acquiring the PET for 25 minutes for the pelvis at that time. And those 25-minute PET images are exquisite. I mean, we call them super PETs, and we pick up stuff there. And if I don't know, studies need to be done if that would have an impact on your management.
Yeah, no, absolutely. I mean, because a lot of these studies, and again, like I said, I'm, you all know the literature much better than us, but I know that some of these studies, where they did the lymph node, like the HOPE trial from UCLA, UCSF, when they did histopathology, actually a lot of those lesions or those lymph nodes that were missed on the imaging, they still stained positive for PSMA on histopathology. So like you said, it makes sense that if you give them enough time, that they will light up, because they definitely express PSMA. It's just the sensitivity of the scanner may not be, or may just need longer time.
Yeah, currently our PET CT resolution is around 8 millimeters. With time of flight, we do pick up 6 millimeter lesions.
Okay.
So, but 4 or 5 millimeter nodes may be difficult for the current routine clinical scanners. But the PSMA, sometimes the contrast is so high that we do pick up small lesions. So, but I'm glad we need to hear from you guys, because that's where we can focus our further work.
Right.
Because we need to work towards making a clinical impact. So hearing from you and what is useful to you and how you use the information is very useful for our community to know and gear further studies in that regard.
Right. No, thank you.
We at UCLA, we just have received our PET MRI. It pulled up to the parking lot and is being installed
Nice.
about 2 days ago or something like that. So, Leonard Marks at UCLA is the pioneer in focal therapy, and Robert Ryder is our champion for prostate cancer, and he's a surgeon, but has been doing some of these PSMA guided surgeries, as Akshay showed during the lecture. And I think you'll see some of this work coming out of UCLA in the next year or two with PET MRI.
Awesome.
Yeah, that's great to know. From the time it was delivered to the time we were able to actually do the studies at Emory, it took us almost 9 months to a year. Isn't that right, Amol?
Yeah, it's like a baby.
Yes, it took. And I do echo Amol's thoughts on that using PET-MR, so PSMA PET-MR, we really have picked up some interesting cases that the diagnostic imaging would not be picking up on its own. So I think that is a niche where we need to get more feedback and sort of hone in on that.
Right. No, I agree. And that's good for me to know. For us, it's all like, we don't really know. And it's good to know that just by the fact, I know that MRI is slower than CT, but that's all I know. I never kind of thought of it conceptually like Dr. Thakurkar, and you just explained that, yeah, by just increasing the time, you may get more sensitivity with the PSMA. So that may be a really good benefit. And it also is kind of one-stop shop. And I know there was an article published with the same name for prostate cancer patients staging, that if you just send them to a PSMA PET and MRI, and that's all they need, nothing else, and they're done.
Good morning, Dr. Sood. Wonderful talk. Thank you so much. Truly enjoyed it. Quick two questions, if I may.
Yes.
But somebody else has others. One is, in your practice, as you are looking at PSMA scans and planning surgery and performing such, what have you found to be the most common, or maybe few most common causes for the false positive results that we report? False positive.
With the PSMA false positive?
That is correct.
I see. Yeah, that's a good question. I would say in smokers, for some reason, we get a little bit of false positive, and it's kind of a known thing. At least for kidney surgery, we know that smoking causes a lot of perirenal inflammation. We don't really know why. Maybe it's just the fibrofatty tissue gets inflamed. That's one of the reasons why we have seen a little bit of false positive in smokers. And this was just actually Dr. Batala, who's one of the radiologists here. He was just commenting on that the other day. I'm trying to think what others. In lymph node disease, I'm trying to think what usually causes false positives for us.
Do you see quite a few false positives?
No, not really. Very few, but I'm just trying to think if I remember. I know in prostate, when we see false positive, it's usually an artifact of the biopsy or patient having prostatitis before. But in the lymph nodes, just trying to remember, the only thing that comes to my mind is the smoking thing, because Dr. Batala was just mentioning that the other day. But it's very low that if the PSMA said it was positive and it was actually negative. So it's a very low false positive rate for us. It's mostly, I mean, sometimes we, will actually refer the patient to radiation therapy based on the PSMA results if the patient doesn't want to be enrolled in a trial. We only do surgeries on PSMA PET positive, patients who have nodal positive disease on PSMA. We only do surgery for them within the confines of a trial. We don't offer them just out of trial surgery. If they don't want to be part of trial, then they go for radiation therapy and medical oncology treatment.
Yeah. How about sympathetic ganglia? Do they oftentimes or sometimes confuse issues? There's some uptake in sympathetic ganglia. No.
Not much for us, especially because the regions we are looking at usually are not that close to the sympathetic ganglia, at least for prostate. So it usually doesn't confuse us much.
Yeah, presacral. No.
No, usually maybe we very rarely do pre-sacral. We usually do pre-sacral nodes for maybe for bladder cancer.
Sure.
But for prostate, mainly we are limited to kind of like the bifurcation of the aorta, and we'll just take common external. So
right. So when we see pre-sacral positivity or suggested positivity, you don't typically explore those regions quite as often. Therefore, not likely sites.
Right.
Okay, that's very helpful. And then the second question, real quickly, anything in your experience with the prophylactic prostatectomy in those with high risk, family history or genomic layout?
Right. No. We have never done that. Actually, there is data actually coming out even that you can perform active surveillance, so yeah, the genomic history.
Well, yeah, active surveillance has been around for a good number of years.
Right.
Hopkins has large database. Right. But in as far as the prophylactic, not many have or talk about it yet. I believe University of Toronto is one of the sites, right, that does prophylactic, or at least studying prophylactic prostatectomy. A common topic, of course, in other cancers, such as, say, breast cancer and prophylactic mastectomy, we all heard about.
Right.
But when it comes to prostate, not so much.
Yeah, no, it's a very interesting question. I'll have to look that up. I actually did not know that University of Toronto was offering prophylactic prostatectomy, so I'll definitely look it up. But
they might not be offering, but they certainly write about it.
Okay. No, I'll be very curious to read. I know that here and the other places I've trained at, they don't really. I've never heard anybody talk about it.
Well,
and I know the reason I was bringing up active surveillance is that there is enough data to say that patients who have family history and who have all these genetic risk, like even BRCA mutations, now we know obviously plays a big role in prostate cancer. So there is series from Northwestern that has come out that even in those patients who do have strong family history, just like breast cancer, actually you can even do active surveillance with the diagnosis of prostate cancer. So that's why I was saying, so that's why I think it's unlikely that at least not a lot of people are gonna, or at least right now they're not offering it, because when you have an established diagnosis of cancer, even in these high risk patients, people are still comfortable watching it. So I don't think they're performing prophylactic, but maybe, I'm sure there's some data out there. And like
there is data. There is data. We just don't seem to be, at least talking about it.
It's interesting.
Right. I think men are a little bit, not quite as brave as our better halves. That's all it is. I suggest. But thank you so much. Wonderful discussion, and I appreciate your input so much for us yet to learn, isn't it? Thank you.
Yeah, thank you so much. Yeah.
Fantastic. Thanks, Mark, for your insightful comments and discussion. I think we are a few minutes above the hour, and I want to say thank you everyone who joined. Thank you, Dr. Sood, for the wonderful talk. I hope everybody has a good weekend. See you next time.
Thank you so much.
Thanks. Take care, everybody.
Thank you.